I will start just by saying hello to each and every one of you who are taking time out of your days to come participate and learn from Dr. Mark Gold. I'm Dr. Kim Dennis. I'm the co-founder and Chief Executive Officer, Chief Medical Officer of Suncloud Health. We are a residential PHP and IOP treatment center located primarily in the Chicagoland area, where we have adult and adolescent programs. We have two adult residential units. One is for complex co-occurring psychiatric illnesses, eating disorders, addiction, dual diagnosis, and the other is specifically for co-occurring eating disorders and addiction. And then we have an adolescent residential unit, which we are very excited about, that will be coming online in November of this year. I have the great honor today to be hosting this webinar, and I'm delighted that Dr. Mark Gold has agreed to participate with us. Dr. Gold is somebody who I first, learned about, read about when I was in medical school, and I've followed Dr. Gold's work since and have been blessed to meet you, Dr. Gold, to be mentored by you, to be one among the many, many, many hundreds or thousands of us who've had the benefit of your mentorship and leadership in this field. So I'm going to read a very, very, very brief version of Dr. Gold's bio because we can spend the whole hour and a half reading about Dr. Gold's career. So here we go, brief version. Dr. Gold is a foundational figure in addiction neuroscience and medicine, an inventor, teacher, researcher, and advocate whose work has shaped how addiction is understood, treated, and integrated into public health. Dr. Gold earned his undergrad degree in psychology with honors from WashU in St. Louis, where he was Phi Beta Kappa, followed by an MD from the University of Florida College of Medicine, and he completed his psychiatry residency at the Yale School of Medicine. His academic and professional roles include distinguished positions at Yale, the University of Florida, USC, Tulane, and Washington University School of Medicine. At UF, he chaired the Department of Psychiatry and founded the Division of Addiction Medicine, as well as established the Florida Recovery Center. Dr. Gold began his career in translational neuroscience in the early 1970s, where he developed pivotal models of opioid addiction. He co-authored the dopamine depletion hypothesis for cocaine addiction and offered groundbreaking insights onto cocaine's addictiveness. He advanced research into behavioral and food addiction models as well, co-editing the textbook Food and Addiction, and co-chairing key conferences to advocate for recognizing compulsive overeating as an addiction-like behavior. He is a distinguished fellow of the American Psychiatric Association and the American College of Clinical Pharmacology. He has received numerous prestigious awards, including a Lifetime Achievement Award from the DEA and NATAP, the Addiction Policy Forum's Pillar of Excellence, and ASAM's John P. McGovern Award for contributions to addiction treatment and public policy. He was recognized as one of the most prolific and brilliant addiction experts by JAMA. He's authored over 900 scholarly articles, 12 professional books, 15 general audience books, and numerous chapters and practice guidelines. He's renowned as a mentor, having guided many addiction researchers and clinicians, including NIDA director Nora Volkow, Nicole Lavina, Ashley Gerhardt, all of the people that I look upon as giants in this field, and he continues to teach widely across the globe. So without further ado, I'm going to turn it over to Dr. Gold, who is going to share for up until around 12:15 Central, 1:15 Eastern, and then we'll have 15 minutes for questions and answers. Please do put questions and answers in the Q&A box, and there will be instructions at the end around how to get your CE or CME. You'll also receive an email after this with a link to get your certificate.
Well, thanks very much. That's too great of an introduction, and your career and working with you has been a blessing to me. So I really am happy to do this talk, and I appreciate it being remote. As some of the people know, I had surgery recently, and it would have been impossible for me to travel and do the speech. So I'm recovering quickly, and I expect to pick up where I left off soon. But this talk gives me a great opportunity to think about some of the contributions that I've made, some of the contributions that my mentees have made, some of the reasons we know what we know about opioids, about speedballing, and about drugs of abuse in the United States. And there's no way for me to cover everything. So hopefully there'll be a part two and a chance to do this again. But I think Kim would appreciate this. And when I put together the introductory slide, I'm saying what kinds of things were really fun and not well known. I think it wouldn't be known that the hit TV show Breaking Bad, which I have a picture myself there in the bottom right, works so closely with the DEA to get a real understanding of what methamphetamine cooking, preparation, sales, and then work with scientific experts to understand the effect on people. And I think part of the reason that show was so successful was its authenticity. In the other side, I have lobbying efforts with Patrick Kennedy, and then working with the Obama administration and Michael Botticelli in advocacy. But recently, I did have the chance to revisit the Andes and to revisit some of the cocaine production and historic use. And I'll hopefully get to some of that as we go along. But it's just a fantastic trip to remind myself that to talk about cocaine or talk about speedballing to indigenous people in the Andes is pretty ridiculous from their point of view, as cocaine is a leaf that they chew to derive some energy to work at high altitudes without food. And that ceremonially, cocaine tea is also used and used safely. But here we've developed a way to, number one, extract it from the leaf as cocaine hydrochloride, to convert it to a sulfate and smoke it, to mix it with opioids and inject it. And as you follow the drug trends for the opioid epidemic and opioid deaths, it's hard to ignore the fact that so many of them are now speedball-like, methamphetamine and fentanyl, or cocaine and fentanyl, injected or smoked. And we'll get into that as we go along. So I thank Kim for all the awards. I think the thing that's maybe of interest with awards is they do encourage me to keep going. But the first award, I think, was the most relevant, and it's the most relevant to this talk, and would be not widely understood. The discovery of clonidine and lofexidine as anti-opioid withdrawal treatments was built on a foundation of basic neuroscience, which was about 5 years of my work, from rats to non-human primates, trying to identify where in the brain opioids acted, what they did, what was the neuroanatomy of opioid action, what's the neuroanatomy of opioid withdrawal, and how could you reverse that with opioids or with drugs that acted on the same brain systems in parallel. And that's principally how this invention came about. And so, what John Crystal recently said in an introduction, and I think that's probably true, that it was the first real translational research in the same group with the same people progressing across different animal species to man with a test in humans and continuing to this day. It was very, very useful, but nowadays I think you'd probably be able to do it all with artificial intelligence and computer simulations rather than in animals. But it was a really great award for me and started my career. Um, I had, like Dr. Dennis said, I'm proud of my NAATP award because those are the people doing the real work with the patients. I'm a person who lives in a laboratory or thinks about how to make things better. They actually make things better one person at a time. And I remember in 2006 accepting the award and saying, I'm not retiring. And so each time I would get this, I'd go like, I'm not retiring. And I said, like, I'm just not retiring. And I said at the ASAM meeting 10 years ago, no, I'm not retiring. And I mean it, I'm not retiring. So at the University of Florida, when I did retire, they put me in a position of distinguished alumni professor, which was university wide. And I got to hold that position for 2 terms. It was very, very helpful for me because I pretty much was siloed in my own laboratory and then taking the Department of Psychiatry. But this gave me a chance to meet with people in pharmacy, to meet with people in veterinary medicine, to meet with people all over the university. And I've kept that up. Um, I have lots of friends now in different parts of the university doing research and thinking, and that's been great for me. Um, Even the having a white coat ceremony, I'm not finished. So the last award, Jean-Luc Cadet, and I think Jean-Luc came to Suncloud to speak about methamphetamine before he retired from NIDA. Um, it's great to get awards, but I'm not finished. So to prove this, I'll say if you look online for the like the Chat GPT version of the most referenced researchers, Nora, rightly so, is number one, and George is close behind. But I'm holding pretty steady at 12 or 13. So Kim mentioned that I spent a lot of time in drug education, and to me that has always meant writing academic books that help explain how addiction is a disease and what we can do about it. And that included trying to educate our colleagues. So I was the first addiction editor in Up to Date, which at that time was a revolutionary, continuously updated online, if you would, encyclopedia of medicine and how to for house staff, interns, and residents. And that 10 years really helped me develop an understanding for what internists knew and needed to know, family doctors and other doctors. I got the chance after UF to be the chairman of the DEA's Global Lecture Series. And that to me was a different way of providing education. And to give you an idea, we got the chance to broadcast nationally and internationally from DEA headquarters the use of ketamine for treatment-resistant depression at a time when it was not approved and when there might have been considerable concern about Spravato for treatment-resistant depression. And we also had panels talking about methamphetamine and brain injury and nitrous oxide. And all of this, I think, built bridges between the various branches of government and the research community. I'm very happy about that. I've always been on education as an editor. So when Floyd Bloom was the editor of Science, I'd review for Science. And you can, in the process of peer review, give people input. And you're not their mentor, but in a way you could help them do a better job. For ASAM, this is kind of a funny story, but when ASAM had its first edition of its textbook, I think I had 7 or 8 chapters. And now I only have 1, which goes to show you just how the field's advanced, how many experts there are, how many practitioners there are. So it's not just in membership for ASAM, it's in experts and availability. When we used to say you should contact an expert in your community, an ASAM certified expert, people would say they don't have one, where nowadays you could have one. And I'm doing a lot of stuff like that. Let me give you an idea about some of my current projects. I edit journals, and we did a good one on psychedelic and interventional psychiatry, another one on addiction medicine. We just finished, as of July, Brian Furline and I putting together all of the addiction medicine chapters into the Encyclopedia of Neurological Sciences. We're very happy about that. It wasn't included at all. And we just finished, I think, had Ashley Gearhart come to Suncloud from the University of Michigan. We just finished the 2nd edition of the Oxford textbook of food and addiction. And that includes now Mark Potenza, Kelly and I that originally put it together. And then our mentee, Ashley Gearhart, who's leading this field right now and has just done a fantastic job. I'm still working at WashU and doing what I try to do, which is sit back and think of some high impact project that might not have been thought of in the past. And with the former chair, Chuck Zaremski and Doug Covey, both of those people were the principal basic science force behind neuropeptides in treating postpartum depression. We're working on some translational research right now that we're very excited about. And I'm hopeful to be able to present something related to that within the next 6 months. I have a podcast I'd recommend, of course, but I have friends, colleagues, mentees, and get the chance to cover topics in long form. So with Brian Furline, we covered the opioid epidemic and how to treat somebody in the emergency room. With Sarah Vinson, we covered her work in young people and people who don't have access automatically to the same kinds of treatment that Bob DuPont and our group reported for impaired health professionals. Chuck Zaremski, Kevin Hill, a really great one on cannabis and cannabis uses in medicine. And of course, my old friend David Smith, Dr. Dave from Haight-Ashbury, we got to reminisce about Woodstock. I also write once a week for Psychology Today. That's fun for me, and you might like that. So, how did I get in this field? And well, the 60s. It's my generation. So, was the drug generation. I went from high school to Washington University. And in my podcast with Chuck Zarumsky, and it's funny, I got to call it the gold standard. I was very happy about that. I said about how it was just very important for me to be at a place where I could just run around. And in a way, it was like how I ended at UF, being able to go from place to place to place. At WashU, I was an English major, and then a history major, and then a psychology major, and then I ran to the med school and got to meet Sam Guzay and John Feiner, who wrote the DSM criteria. And there are many things that I learned there, but I did learn that I was interested in what makes a drug of abuse. And at that time, a drug of abuse could be defined as anything that was self-administered by lab animals. And that was a basic science definition. A clinical definition was overweighted toward withdrawal, so that only drugs that had a pronounced withdrawal syndrome were drugs of abuse. And that's why John Feiner and the DSM did not include cocaine as addicting. And I'll probably talk some more about that, but cocaine was not considered addicting in the research diagnostic criteria, in the DSM-1, in the DSM-2, in the DSM-3, and I spent about 10 years proving it was addicting. So mostly all of this work comes about through an interaction with other people. And I think Kim and I, it would be the same thing. Would be she has an idea, I have an idea, together we have a better idea. That's kind of just how it worked. On the other hand, when you're a student, you don't know anything. So lucky for me, I'm at WashU as an undergraduate, and there's Rita Levi-Montalcini and nerve growth factor. She's going to win the Nobel Prize for this, and I'm going to end up using this work later on to show some of the detrimental effects of methamphetamine on the brain. But pioneering, great person. I got to visit her 2 times in Italy after she went back home, and just really outstanding experience for me. Similarly with John Feiner, who's pictured here, thinking about psychiatry from the point of view of what is a diagnosis. And this wasn't straightforward. Early on, a diagnosis might be your countertransference. Other people said a diagnosis should be what you respond to in treatment. So maybe a diagnosis should be lithium responder. But Feiner said it's more about what is replicable, and you could just rely on one observer or another coming up with the same diagnosis. Very important for me to understand. And also, being there at the time, the principal modality of treatment there was ECT, and very useful. I went to Woodstock, and Dave Smith started Haight-Ashbury in the 60s, 67. And there were rock tents, rock doctor tents that he inspired, and where people could help other people who had problems. And I got to interview Dr. Dave for Psychology Today, who reminded me of a number of things that he's the one that said healthcare was a right. He was the one who offered absolutely free treatment to anybody in the San Francisco Bay for medical concerns and addiction concerns, and kind of a storefront genius of addiction medicine, the role model for many people, me included. He would detox people in the street, in the home, in his clinic, wherever they were, uh, rescue them with naloxone, wherever they were. He's got home movies with Janis Joplin, for God's sakes, and the Grateful Dead. And in the course of our multi-decade relationship, I even got to understand the finances of the Haight-Ashbury Free Clinic. How could it be free? And it was benefit concerts. The celebrities who lived in the Bay Area and the rock stars supported this venture for him, and he didn't disappoint at all. We other thank you to the family, of course, and we're all very lucky. So they let me work, and uh, they'll wear Washington University and St. Louis hats if I give them some encouragement. So I'm always thinking about how we get addicted and what are the various factors. And there are factors like trauma. There are factors like early use. But as an animal researcher, I was mostly focused, as Dr. Dennis said, on the dopamine systems and the noradrenergic systems, which you might look at as the pleasure versus pain systems. And these will be all the institutions that made it possible for me to do my work. And I'll go through these collaborations and think about them. And the people I can't really say enough about how they made it possible. But if you're not a clinician, you need clinical partners. You could have a great idea, but no one would try it. And I've been lucky to be able to do that. So I was at the opening of the Betty Ford. I was on the foundation board and would be active at the Betty Ford and thinking about that model of treatment. And also, the Betty Ford used me to try to develop very early treatments for cigarette smoking cessation. And there are two things that you probably don't know. When Betty Ford opened, they did not do detox. So treatment was considered treatment. Um, of course, they had um, Mrs. Ford as a role model mentor and built a program around James West model, 12-step model. But for me, every time I went, I said, we have to do something about tobacco smoking. And it was a big problem because even though focus was on alcohol, the number one cause of death among alcoholics is not alcohol, it's cigarette smoking related at that time. So we worked very hard on it, but we never really made a dent in this because of probably the rigidity of the original model. But all of these founders were just amazing. Doug Talbot, um, Jim West, Conway Hunter. And so we would have an annual conference where I represented science and they represented big book. And we would just duke it out. Like I would say, all drugs have the same net effect on the brain. You can't ignore tobacco. And they would say, you have to deal with the alcohol first. And it was just, again, without clinical partners, I wouldn't know very much. The same would go with Benny Prim, who taught me about methadone in the clinical setting of Harlem Hospital and about HIV and all sorts of things. And I got to have him as a visiting professor at the University of Florida, which was just great. Everything changes, but they stay more or less the same. So when I started at UF, I said, well, I'm interested in the opioid systems. And my mentor at that time, who eventually became one of the directors of research at NASA, said, well, that's very hard to study, but we'll give you a shot. And so the first time I did the locus coeruleus project was in 74, thanks to these guys. The first time I saw the locus coeruleus in humans was in 74 and 75 by the chairman of neurosurgery, who let me do 6 months with him. And we learned that the locus coeruleus was really a blue spot in the brain. Some neurosurgeons considered it a panic button, that stimulation of the locus coeruleus would cause increased pulse, increased respirations, fear, and panic. And it looked like that might mimic what you see in naturally occurring opioid withdrawal. And that's where I ended up with Herb Kleber, who at that time at Yale, you could not take addiction medicine. So I had to do my regular internship and residency and moonlight in the storefront clinics because opioid use disorder was not considered part of any training program. And actually, I got called into the chairman's office for a career lecture, advising me that I'm wasting my career and time thinking about, quote, these people, unquote. Um, Kleber had a different point of view, but he was a one-man division. He had worked in Lexington in opioid use disorders, had thought a lot about methadone, and so I got, with his help, to learn how to evaluate and treat people with opioid use disorders in the uh, early 70s, to save people with naloxone, to give people methadone, and to use church basements and AA because we had no other treatment available. Now, we did start to get some church treatments with Daytop Village and other long-term treatments, but almost nothing was available. What did I take from that? Kleber always said that drugs change the brain, and there's no guarantee they would change back. And that's stuck with me my whole career. If you think about opioid use disorders, there are people who have opioid use disorders that need replacement forever. And that will be understood someday. But my weak attempt to understand that was to say that at some point there's a dose and duration of self-administration of opioids that break the endorphin system, and they are difficult to repair, meaning that opioid replacement would make a lot of sense. I went on to thank my mentors at Yale, and um, we had a retirement party for them. Eric Nestler and Dennis Charney and John Crystal, and I, congratulating them on their retirement. But again, just like working with Levi Montalcini, working with George Agajanian, whose work is the core basic science for opioids and noradrenergic systems, was just a tremendous gift. And he also was really Dennis Charney's basic science and John Crystal for the use of ketamine. Um, our own department in psychiatry at UF had its 60th anniversary, and I got to celebrate that. Some work was difficult to do at UF, and this is I was interested in how um, uh, drugs might be similar to process addictions. And it was very difficult to do this work in the United States, but we developed a functional imaging lab in China. And with the Chinese National Academy of Sciences, we're able to do obesity related imaging and also pornography related imaging work, which I think have been really pivotal in Mark Potenza's work and in Ashley Gearhart's work. We also got the chance at UF to set up secondhand smoke lab. So that would be related to opioids. And I don't know if I show this slide, but we did the first and only study of second and third hand opioid smoke exposure. And we did that with a 5-year grant physically in Afghanistan, looking at children of opium smokers. But at UF, we pioneered the smoking rat lab, showing that secondhand smoke was actually firsthand smoke, but you didn't give consent, and that you could cause changes in brain markers and growth factors like Levi-Montalcini studied, suggesting that all drugs might have their own unique toxic footprint or fingerprint, that you could find residual change long after the drugs were gone. And this work is continuing today with both Kevin Wang and Firas Kobayashi. Scott Teitelbaum, who you might know, helped with the clinical patients at UF and the questions related to impaired health professionals, being a pediatrician who became a professor and division chief. This may, you may wonder like how ASAM got started and how we trained the original people. Everyone was trained in apprenticeship. We didn't have fellowships. We had apprenticeships, and people would come to work for you. There were no board exams. And we would train them. And Doug Talbot did this, and I did this, and Conway Hunter did this, and Jim West did this, and that's how the field had its original clinicians. Most were not psychiatrists. And like Scott Teitelbaum being a pediatrician, Doug Talbot being a urologist, and Conway Hunter being an OBGYN, they added a great deal to the field, especially because of how common it is to have comorbidities. So if you're thinking about opioid use disorders, you have to always be thinking in the old days about TB, about HIV, about all kinds of diseases related to the lifestyle and related to needle risk or smoking risks. And having these other doctors just added a great deal. We started a fellowship at UF almost right away, and many of the fellows became chiefs at other treatment programs. We had one at UF, as I said, another at Georgia, another at Tulane, and one of the fellows that we trained, who Cementi just was on the FDA antidepressant panel and texted me, and I was so proud of her because she went back to be principally an OBGYN, but she's trained as a psychiatrist and in addiction medicine, and she was the only panelist to disagree about the use of antidepressants during pregnancy. A lot of great mentors I mentioned. How do we know the locus coeruleus is involved in opioid withdrawal? Simple. Put an electrode in it. Give it morphine. This firing rate goes down. Give it naloxone or Narcan. Firing rate goes back. Give it morphine, 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 morphine. It goes and gets a peaceful calm because you just made it dependent. Give it naloxone, a release and hyperactivity way above baseline. And that's really that work. My contribution was mostly about the parallel system, the alpha-2 adrenergic system that clonidine and lofexidine access and can reverse much of the hyperactivity. Had I learned so much about cocaine? Lucky. I had a mentor, Bob Bick. He translated Sigmund Freud's cocaine papers and was incredibly interested and interesting, and worked really hard to review most of what I wrote about cocaine. I'm doing something in Psychology Today right now on lidocaine and xylocaine, and it's amazing because Bick at that time had studied cocaine versus lidocaine in the Yale gym and showed that you couldn't really tell the difference between sniffing one or the other. And it was eye-opening for me how drug use is so contingent on set and setting. And Bic helped me understand the pharmacology of smoking, so that smoking cocaine in terms of time to the brain was equal to injection, and that smoking allowed you to also smoke something else. Another mentor of mine was Bart Hubble, who trained by B.F. Skinner and just like me was an animal self-administration guy, but really he moved into sugar, showed that sugar was self-administered by lab animals, showed that sugar was self-administered by lab animals, and they became obese, showed that you could even feed pregnant uh, lab animals too much sugar, and their offspring became sugar preferring, and went farther to even show that that sugar preference transferred even to alcohol, so that they would be alcohol preferring. Also in the lab next door was my friend Barry Jacobs, who both of these guys made it possible for me to think while I was trying to understand cocaine's effects on the brain and behavior. The most practical mentor and who worked with me forever, I mean, since he was drug czar, I got to give him an award at the in Washington, D.C. recently, and it was a great honor, Bob DuPont. So DuPont, again, studied methadone. He was a Democrat, but in the Nixon administration, showed that methadone had a decrease in, caused a decrease in crime, and to this day has been active, involved in looking and thinking about opioid use disorder and replacement treatments with methadone. DuPont also went on to help with a 5-year Robert Wood Johnson study, our group look at treatment outcomes for doctors. And the two things that are worth noting is, one, their 5-year outcomes. Two, we had opioid use disorder doctors who were not treated with as the same as other people. They were treated mostly with detoxification and abstinence. But the main finding here was just that participation in impaired health professional programs allowed physicians to have excellent 5-year outcomes, excellent return to work rates, and excellent outcome measures. All of this is back to the questions of opioids, cocaine, and lessons from Bob Bick and just life. So SUDs are difficult to understand for most people outside of the field because, as I said, if you talk about cocaine in the Andes, it's not the same as talking about crack or cocaine hydrochloride injection or speedball. So you have to keep in mind the drug itself. What is it? Then you have to think about the route of administration. So yes, Coca-Cola had cocaine in it, but it's irrelevant because it was orally administered and the cocaine equivalent was easily replaced by caffeine. That's quite different than IV self-administration. Dose. The dose is a critical dimension. So again, think about it. When I first was training, all the patients that we saw with opioid use disorder were heroin users. We had no fentanyl. We could rescue almost everyone if they came in to the emergency department with 1 amp of naloxone. Overdoses were so rare at the time that naloxone, Narcan, was an orphan drug and nobody used it. And the main users of naloxone were anesthesiologists that kept it on that cart for surgery in case they gave people too much opioids to just reverse that. there was hardly a market in the emergency department. And um, I mean, it's dose is really important. Duration of use is critically important. Uh, Fit in the brain, like is it a specific fit, like cocaine blocking dopamine reuptake, kind of the endpoint of the reward cascade, or out there? And then I added to Bick's um, paradigm here, neurotoxic and residual effects, which are often ignored. Just think about it. In the midst of the opioid overdose epidemic, most charts do not even have how many times the person overdosed in them. They don't have how many times they had an overdose that was reversed by Narcan in it. They have, we pretend like um, overdose has no consequence when for people with opioid use disorders, when we make a big deal out of people who've lost consciousness for head trauma or uh, cardiac arrest and needed resuscitation or drowning or what have you. All of those are hypoxic events worth paying attention to. The user. Uh, Bick knew a lot and thought a lot about the users. Um, and me as a neurobiologist, I didn't think that much, but they eventually my training wore on me and I started to pay attention to it. So there are pre-existing vulnerabilities. One might be exposure in utero. One might be uh, exposure early in life. And we showed for children of opium smokers in Afghanistan that they had real consequences of both. Psychiatric disease. You could, who's left smoking cigarettes? Mostly people with major psychiatric disorders. So having and trying self-medication um, can facilitate and perpetuate addiction. Sexual, physical, emotional trauma, and PTSD, yes. Um, Age of first use, teenage use versus hospice. No one is worried about cocaine in a Brompton cocktail given to people in hospice. Genetic and epigenetics. We didn't know very much about that back then, but we are learning a lot about it now. And Jasmine Hurd and her work on cannabis, I think, is really important, and it's important to pay attention to. I mentioned second and third hand. There's the whole polydrug. So just when we talk about the opioid epidemic, in general, we're thinking, or the public is thinking, that it's one drug, where that's very rare. Even if you buy a street drug, the average street drug has 3 or more active drugs in it. Um, Personal characteristics, poverty, social standing, unemployment, LGBTQ, risk taking, etc. All of these are key factors. And it's what makes addiction psychiatry confusing and difficult for people. Um, Post use comorbidities, loss of function. Like even in the impaired health professional cohort, when FCC looked at it, there was a loss of neuropsychological and intellectual function that could not be ignored. And while this is not widely reported, it's important that there's decrements of function. And if you're working with someone and trying to help them, you wouldn't want someone who to rejoin a profession where they're not capable. So we don't do very much fitness for duty or fitness to return to work. But when we did do that at FRC, we did find that many of the physicians that were surgeons felt better as taking a fellowship in addiction and practicing addiction medicine. The environment, availability, that's related to the price. And I always say that cigarette smoking at $8 a pack is quite different than the 60s at 15. And then stigma. Of course, cigarette smoking was stigmatized and was the main public health intervention for smoking. But we're seeing a change in alcohol drinking without really stigma, just on the basis of education. I think that's a good thing. That's actually me. But the clinical impact was we had new treatments, we showed research mattered, and we could show that research in the laboratory could affect clinical care. We could change how people think about opioid use disorder and how we might approach it. And we might even, a 1979 paper of mine is widely referenced as saying that this kind of connection between the endorphin system is probably what's targeted by opioids and undermined. And there's positive effects, negative effects. So for locus coeruleus stimulation and withdrawal, opioid withdrawal, you have pain, suffering, the feeling that you're going to die. Just the relief of that is positive and reinforcing and adds in the feedback loop. And I listed all the main things we did, but it wasn't a one clinical trial. It was 5 years of work, which provided the basis for understanding this complex system of neuroanatomy. Drugs change the brain. Drugs change the reward system. Chronic drugs might compromise the reward system so that in a chronic drug state, you might have, even after detox and long or treatment for long periods of time, you might have persistent anhedonia. That's really important, and we may have to treat that. And then maybe there will be treatment for that. And thanks to all the mentors and mentees that advance the work forward. You heard Dr. Dennis say that our work on cocaine showed that cocaine was addicting, helped people understand the critical role of dopamine in drug reinforcement. And by making it clear that cocaine could be addicting without a major abstinence syndrome, we led the way for gambling and other process addictions to be considered addictions as well. So Charlie Dacus did the great work on that. We worked in contingency management for cocaine and even used to try to give people lottery tickets for coming to groups. We added a lot. It's interesting, and most people wouldn't know that our group showed that buprenorphine helped reverse fentanyl-related anhedonia early in the epidemic, and all that was possible because of secondhand opioid administration. We also showed, I think that's really a highly referenced paper, that you could have secondhand cannabis exposure and precipitate cannabis withdrawal with THC antagonists, and you could have secondhand nicotine exposure and precipitate withdrawal, and then again, smoke drugs in high concentrations that you're exposed to change the brain and can cause dependence in this same way. And so a mentee went all the way from postdoc to full professor on that work. And we extended that to children in Afghanistan for Mrs. Clinton, Hillary Clinton, and the State Department in a 5-year study. And the great part of this was Bruce Goldberger, who I did this work with. I got to work with him on just a crazy experiment showing that Starbucks decaffeinated coffee had caffeine in it. In China, we showed that if you like McDonald's French fries, your brains light up like an alcoholic's brain when they see their favorite bottle. Jean-Luc Cadet, again, did his career looking at toxic effects of methamphetamine, that not everything is reversible. And while not, this is important because you might, if you deny that drugs change the brain in some ways irreversibly, you wouldn't invest in treatments that are regenerative. And there are regenerative treatments out there. Nora and others are trying TMS, and I think you're seeing TMS being used in stroke. You're seeing TMS being used in neurological diseases, even age-related memory disorders, and just and other treatments like exercise. So I really think this is an important series of studies that Nora and Peter Thanos and Jean-Luc Cadet have done. And it's especially relevant now that we're in a synthetic epidemic, meaning that the old time speedball was cocaine and heroin. The new time is methamphetamine and fentanyl, all manufactured drugs in a laboratory, and the new wave of the drug epidemic. This is tragically David Patterson Silverworth, a mentee of mine, passed away in 2020 of brain cancer, early 2020s. His work is, again, not very popular, but should be. And that is, if you look at people with opioid use disorder, you can find that they've been in the same treatment 8, 9, 10 times. And so we have one treatment modality for them. He said it made no sense. Should look at every case individually, especially if someone failed in traditional treatment. And this work, we had a recent, me and the Mayo Clinic group, recent piece in the ASAM journal about what it would mean, what does it mean to be treatment refractory? And I think this is going to be important because the field has traditionally blamed the patients when they fail or drop out of treatment, where you might think that rather than blaming the patients, the treatments are just not that good. In the Psychology Today, we covered the speedball crisis and the education we need about that. There are a lot of missed opportunities in this death crisis. And a mentee, Ben Shrivastava, looked at naltrexone underuse, prevention underuse, and also how many overdoses are actually passive suicide attempts. And I think that's, again, under studied. So there is a good McLean Hospital study looking at survivors of overdose, showing a significant number say that people wouldn't have missed them if they died. They thought about dying. They have thought about it in the past. So even though the numbers of people who are planning an overdose or suicide by overdose might not be more than 20%, there's another percent where they're playing with the idea in their mind. You look at Lisa Merlo, has studied physicians. I really like her work as a mentee, but also because she's shown that after the 5-year opioid contract is up with impaired health professionals, almost all of them sign up for another 5 years of monitoring. And she said that just calling an 800 number to be randomized to having a urine or not is a CBT intervention, and that by itself can be very helpful. As I mentioned, the PRN, FRC, by studying doctors for more than 5 years, have shown that there is some decrement in neuropsychological intellectual functioning, and there is the question of fitness for duty testing. Dr. Dennis mentioned the Yale Historic Conference. You can see how young Nora was. I won't show you how young I was, but Ashley Gearhart was PhD student at that time. We brought all these experts together, and it was one thing after the other. We got the field going, and Nicole Lavina um, presented there with Bart Hubble's work, and we worked together. We had the first NIDA grant on food addiction, and now there are lots of them. Just to cover a couple of other things that are out there, the risk and benefits of cannabis. The American Psychiatric Association asked me to put a panel together for their council and do a council report. And Kevin Hill and I studied this for a year with the council and developed a report and published a synopsis. The moral of the story here is mostly that it's been very difficult to find a medicinal effect where cannabis or cannabinoids would be equal with less side effects or better than an existing treatment. We had a great kratom update, CME, and at Tulane, which has been picked up all over. So what do we say about opioids? There are treatment protocols. We've summarized them as best practices, and I spent a lot of time with the Mayo Clinic group doing this, where Brian has improved this by adding buprenorphine induction in emergency room settings. But at the end of the day, most people do discontinue treatment, and there's a need to develop new treatments, better treatments, especially for the treatment non-responders, because we still have a tremendous amount of overdoses. Even when you say that drug overdose deaths have decreased to 80,000, we would far and away outstrip any other country in the world in overdose deaths. So there's looking at psychedelics and other treatments. It's going to be very important. I put this paper up because this is a really early paper from 2018, and it said that we really have a continuation of the epidemic from the time I was in training. Really, it started and just never stopped. And I think that's just adding new populations, moving from population to population and drug to drug with people who have continued challenges that are not addressed. It's quite something to have a life expectancy drop. And now we're in an additive crisis. And I have my piece in Psychology Today will come out today or tomorrow about what's going on in adulteration. But, we had the xylazine alpha-2 addition to the drug supply, the so-called zombie addicts. And we've had all kinds of other things in counterfeit pills, fentanyl, plus all sorts of combinations to make it very, very difficult. So what we know about drug overdoses is the more drugs that are found, the more likely there is to be an overdose death, regardless of the person. The combination of fentanyl, cocaine, or methamphetamine is increasingly common. All the polysubstance use and adulteration is risky, as well as the counterfeit pills. We try to bust the myths. Addiction's a bad choice. People must hit rock bottom. Addicts could quit anytime if they wanted. Only certain types of people get addicted. Alcohol is less dangerous than other drugs. Relapse means treatment failed. Dual diagnosis is rare. Detoxification isn't necessary. Why don't we have a cure? and so forth. And Nora and George Kubin and many others have tried to get this across. As I said, speedballing is this current wave, and with manufactured drugs, making it very difficult for the DEA because they could interdict drug production at the opium poppy level. They could interdict cocaine production in the Andes at the coca plant bush level. They could interdict cocaine as it's being transported to sea, and even shipped by submarine. They have disposable submarines now. But the use of laboratory science, they can make methamphetamine and ship it easily. And with fentanyl, the bulk shipping challenges are easily overcome. Again, making it quite a crisis where we have enough problems before they add xylazine to it or dopamine, and all of that just making people look unresponsive and unable to do anything. While naloxone works, the newer adulteration makes multiple dosing more likely. And I bring up Demi Lovato only to remind everyone that she, or the people that were there, did not say that she overdosed on opioids. So keep in mind that you have nothing to lose by giving naloxone in any kind of an overdose. It was OxyContin laced, but she's done quite well. So keep in mind, medications work. Methadone works. I'd like to see methadone available like buprenorphine. And you wonder, like, why don't all doctors order addiction medicines? Less than 2% of patients with alcohol use disorder are given naltrexone or any alcohol medicine. And this maybe it will be easier if GLP-1s are approved and they can prescribe those, but it is really telling. I spent a lot of time in my Psychology Today post talking about, again, science in the big book. Keep in mind how self-help groups work. They do work. There's geniuses behind almost every saying, and they help people organize their recovery. They break down the isolation. They reduce shame and stigma, and they can prevent relapse. Addiction professionals are just not as available as sponsors, and they might want to help, but they aren't available 24/7, and there isn't a meeting on every street corner. So I spend a lot of time thinking about this and thinking about one day at a time, and saying, well, that's really important, and what do we lose by adding that to our treatment? Very little. I spent a good deal of time trying to destigmatize methadone and help advocate for its more widespread availability. Methadone pioneers, I had the chance to meet. They didn't train me, but they trained Kleber and Bob DuPont. And it's a proven detoxification. It's hard to know why we can't just prescribe it like buprenorphine. But the more people we treat, the less overdose deaths there are. The more naloxone is available, the more we give people a second chance. And we as a field need to think about how we decide when to stop treatment. Because some of the work on opioid use disorder treatment says that the minute that a person stops their buprenorphine, their risk of overdose is as great as the time when they started it. So again, we have good news in overdose deaths, but we have new routes of administration that are catching on and that are alarmingly high. We have new adulterants making it difficult. We have new populations for using drugs and dying. And we do have lessons from physicians, but probably the main lesson would be age of onset. The later you develop an opioid use disorder, the easier it is for us to treat it. We need prevention and delay use and early intervention, and think about comorbid disorders. So just like we think about cigarette smoking for alcohol, think about anhedonia, suicide, and depression for opioid use. And that's a good reason to feel depressed, just being having an opioid use disorder, if you ask me. There's new data from Nora and the University of Pennsylvania's group on fentanyl overdoses. We don't even know really who's had them to put it in the chart and get a history. But the imaging data that I reviewed in this Psychology Today piece is very important to look at, in my opinion, because an overdose is a hypoxic event and so forth. So I know that we have only 2 minutes left, but I do think evaluation of depression, treatment of depression, thinking about what the person brings to their opioid use event in terms of trauma, in terms of what their optimism is and ability to feel pleasure is very, very important. And you're seeing this all over the literature now. We've made good progress, lastly, on gas station heroin, which I covered a long time ago. And there's now understanding that it's just basically opioids. Last but not least, don't forget that people with opioid use disorders not only will use psychostimulants, but they have concurrent behavioral addictions because it's all the same brain system that cocaine targets, that cocaine undermines, and that cause addiction in the brain. So you said to stop, so I'll stop.
Thank you very much. You covered so much in a relatively short amount of time. Um, just want to thank you again for coming and sharing with us today, from the beginning all the way through here and now. So now is the time, everybody, for questions and answers. Feel free to put them either in the chat or in the QA box. And while you all get some questions in there, I can start with a few of my own. Starting with the question that you had at the end, there's this remaining question: when do we stop treatment, right? Which is, if we think of these as, the brain changes and the brain doesn't unchange a lot of the time, why would we stop treatment? We don't stop treatment for diabetes, right? We don't stop treatment for other chronic health conditions, but there's this like nagging persistence of this idea that at some point you should be able to stop the treatment.
Yeah, I
So
mean, I tried this like a long time ago to try to develop like an endorphin test, and we'll have a way to do this someday, but there's going to be this is just, you're asking me, so I'm just spitballing this. You like basically like there's some dose early onset that undermines the whole opioid system, and in my mind would require replacement or treatment forever. There may be some way to get that system back going. But people aren't even trying that. So like TMS would be one way. And clearly, Mark George and other people are looking at TMS for pain through opioid systems, for God's sakes. Well, if you could do that, you should be able to stimulate that system to work again. Also, I really love the work, and I volunteered to be his mentor. It's just funny. But Peter Thanos, who worked for Nora and does exercise, he's he's shown in animals anyway that in a cocaine use disorder model, you can regenerate brain systems with vigorous aerobic physical exercise. And that resonates with me because we used to have this group at the Yale program where we try to get people to be runners. It sounded really silly, but I mean, I did it myself. And we would get up in the morning and take them running and try to get people to run and like be in a marathon. And it wouldn't work for more than, 5 people in 100, but I've seen one of those people in a race for 20 years. They send me pictures. So some people, not only Eminem, some people have been cured by exercise. And if you think about his example, and I'm not totally up to date on his, but he sends around his AA pin every year, medal every year. Maybe he's at 20 years after his overdose. He's totally treated by detoxification, abstinence, and Navy SEAL like exercise. I mean, so extreme they had to tell him to stop running.
Right. So would you call that switching addictions?
I would call
Right.
that great.
In a harm reduction world,
I
that's a
mean,
good swap.
what a switch. You mean you don't die? You mean you only have to do it for an hour a day? You don't have to think about it the rest of the day? Like, it's not even close.
Yeah. 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 Okay. It looks like there's a question in the Q&A here. Oh, will we get the slides?
Oh no, I'll
Yes.
send. I sent Kim. Um, you can send them this my slides.
Yeah. I have a copy of those, and Dr. Gold has graciously authorized me to share those with you. Um,
But on,
so,
for like people who are interested in one thing or another, I do I spend a lot of time on my weekly psychology today. And if you click on the bottom, there's usually another 5 or 6 references. And so I, I write them knowing that people at the NIH and other people are likely to read them. So sometimes they're a bit obtuse, but um, they're meant to be like academic publications for an old person. It says, well, like, what if I pass away tomorrow? I want to say something about adulterants. So anyway, I just basically like say everything I need to say. And it was great for you, by the way, to agree to be interviewed by me for the piece on eating disorders and addictions. And I do think that that's another area where the field is in denial. So just like you need to think about depression, you need to think about eating. And if you don't think about it, it won't go away.
right, right. Yeah, well, I think the addiction field is in some denial about eating disorders, and the eating disorder field is in denial about addiction, and it's a recipe for disaster for people who have both.
Yeah, I mean, it's so funny to think people used to say, like when we first had the Yale conference, I think even the first time I met you, you said, it's like somewhat controversial to say that that food could be manufactured to make it addicting. Now, I don't think you can't find 5 people who are actual experts who wouldn't say, yeah, they do manufacture food to make you like it, to make you want it, to make you crave it, to make you eat more than you should. That's just capitalism.
Right. Right. And when we think about access, as one of the drivers of addiction, I mean, 70% of our food supply chain is made of ultra
Yeah,
processed foods, and the whole population is exposed to it, right? Not just adults or teenagers and older. Uh,
we wouldn't be having this conversation if it wasn't for Bart Hubble, Kelly Brownell, the Yale conference. Part of the thing that was so much fun about that was just imagine you're me and you could invite 100 people to a conference and none of them know each other because all the funding was for diabetes. So Lustig, like they never met anyone who worked in any. They had kidney disease. They had like the diseases were funding obesity, and we bring everybody together, and everybody goes like, "Gee, there ought to be a textbook." Like we didn't even know you could that you like could self-administer sugar, but the uh, ultra processed foods that wouldn't exist without the everybody working together. Just like I said, I have better ideas because of you than I do because of myself, and if you listen, you'll be surprised how much you can learn.
oh, that's exactly right. Um, so let me ask you a couple other questions. What are you most worried about in our current landscape, when it
Well, I mean,
comes
I
to
think I
public
think like that
health?
it's very confusing, and I don't really know. But I'll say I think I think we've made a lot of progress in opioid use disorders and naloxone access and treatment access to buprenorphine. We should build on that and add methadone rather than subtract. So I think that's important. We have to realize that you can't do away with rehabs. This was really a mistake of the former leadership, national leadership, because we don't have a treatment for cocaine. We don't have a treatment for methamphetamine. We don't have a treatment for cannabis. The idea that you're going to like let people stay in their community for we tried that for cocaine. It's a joke. It's just not even remotely possible. So I think even that the public system needs to wrap its arms around daytop level, long term residential treatment for non responders rather than putting them in a revolving door where eventually they die. So
Right.
you have somebody who's overdosed 8 times and you send them to Suboxone outpatient. You're like, how in the world
Right.
it's just so, of course, people are dying because after a while, they do eventually die. The drug supply changes, they add something to it. The dealer has, anyway. So I'm concerned about that. I'm concerned about psychiatry leadership. So I think it's a reductio ad absurdum, and no one at Rockefeller University ever thought that methadone cured people with opioid use disorder. It wasn't like that. It was meant as a harm reduction, and then we'll treat them. Then they would, then we'll get them a job. Then we'll build their life back up. So in a way, the stuff that we do for doctors, just naturally, we don't do that for anyone else. I'm
And we know
concerned.
the stuff that we do for doctors works,
We know it
you know,
works.
right?
So that I think that's concerning, and I do think there's while it was misguided to think about antidepressant exposure in pregnancy, it's very important to think about cannabis exposure in pregnancy, and it's possible that the exposure can manifest itself for more than one generation, according to Jasmine Hurd's work. And that is, who could not be concerned about that?
Right, the transgenerational passing on of epigenetics and brain
Yeah,
changes.
yeah, and it just may be something, just like cocaine insinuates itself in dopamine systems, cannabinoids insinuate themselves in cannabinoid systems, but they have widespread influence, and we don't understand them completely, and we certainly don't understand them at the time of conception and in the early trimester. So I think I gave you four real big concerns. Other than that, I think I'm happy that people like you are out there treating patients. And so I don't have to be concerned about high quality treatment being available. We just have to be sure people retain access to it.
Right, right. So one last question in the last 2 minutes. What do you have your eye on as the most promising innovation for the field?
I mean, most of the uh, AI people and people that I talk to related to that think that the brain computer interface might not even need wires, so that you'll be able to think of something and your AI device will answer you. I think you see that in TMS. TMS is kind of a one way. If you add EEG to high density EEG to it, it is a brain computer interface. Um, and if you could charge up the pleasure system and revitalize it, I think that's an area that Nora is thinking about rather than DBS, like sticking
Right.
something in there. That doesn't really make sense to me right now because um, I'm a full believer in brain computer interface. Our thoughts are, if you think about Stephen Hawking being able to talk through his computer, right now we're thinking that can be done just by thinking the words. So just sit here, think about what you're going to say, and your computer will be able to say it 5 years or less.
Wow. I don't know how many people would want to like read my thoughts, or how many I would want to be able to read my thoughts, but that's really exciting.
No, that's scary too. But I mean, on the treatment side, it would be really nice if we could actually cure somebody.
Yeah, for sure. For sure. All right, we are at the end of our time for today. I want to thank you again, Dr. Gold. What a blessing to have you here today, and just to have known you all these years and to have benefited from your contributions to the field. So
Well,
thank you again.
I'm so proud of you. It's making me younger.
Wonderful. All right, everyone. Expect to get an email from us at Suncloud Health with details about how to get your CE, and we will send out a copy of Dr. Gold's slides as well. Take care.